Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Angelini Pharma.
This program is presented by Medscape Education Global.
Hello, I am Bettina Schmitz. I am an epilepsy specialist and I'm based in Berlin, in Germany. Welcome to this activity, which is called Shared Decision Making in Epilepsy today. We know that shared decision making and thinking carefully about what we communicate with patients and when is very important for setting our patients up for success and on a good path on their treatment journey. But it's not always easy to do this. And in this series of activities, we explore some of the hardest conversation to have with patients and give you our advice and latest evidence to support effective communication and shared decision making. Let's begin with the first segment. It's epilepsy, having this conversation with patients and caregivers. This title might sound banal, however, in my experience, communication is perhaps the most relevant skill in epileptology, perhaps more relevant than reading EEGs or interpreting MRIs. Why? Epilepsy is a very heterogeneous disorder, both with respect to etiology and prognosis, with a potential impact on all aspects of life, and this impact is different from patient to patient. Understanding the paroxysmal nature of the disorder, the principles of treatments, and adequate lifestyle adjustments is a complex task, but necessary for what we call shared decision making and what is the basis of a reliable and effective patient-doctor partnership. We know a lot about what we should communicate and the negative impact of poor communication, because this is relevant for seizure-related risks, injuries, drowning, accidents, avoidable seizure relapses due to poor adherence and lifestyle mistakes, and poorly prepared or even completely unplanned pregnancies. So the knowledge is there, but how can we transport this knowledge to our patients, make them understand and enable them to put our knowledge, our expertise and advice into their praxis? This is not easy. First of all, there might be a mismatch of perspectives. Doctors, from their perspective, might think epilepsy is a relatively benign disorder, much more benign than a tumor, Parkinson's, or dementia, and easy to control in most patients with well-tolerated anti-seizure medication. So they might communicate to their patient, you're lucky, it's only epilepsy. From the patient perspective, however, the diagnosis of epilepsy might be very traumatic. The key concept here is loss, because the epilepsy diagnosis means impairments, losses with respect to all aspects of life: control, independence, career, income, social status, self-esteem, mortality, family planning, fun, and even life years. And it's important to address all these losses at the onset of the disorder and when making the diagnosis. But it's very important that these losses don't become permanent. And of course, the main task we have is to put our patients on a fast track to seizure control, because epidemiological studies all agree that there is a major difference between patients who are seizure-free compared to patients who have active epilepsy. And these impairments relate to mobility, to employment, family planning, to health issues, to everyday activities, and to social stigma. And even in our highly developed countries, there is still misunderstanding, prejudices with respect to epilepsy, resulting in discrimination. What's also important that the reaction to the diagnosis of epilepsy is very different depending on factors such as age, gender, the psychosocial role, resilience. We have patients who might react in a very frightened way and develop a regressive reaction and behavior. On the other side, we might have patients who can't accept the diagnosis and might behave in an aggressive way towards our communication and counseling. We have to consider that acceptance is a process and that this needs time and is particularly difficult in the first morning after an epileptic seizures when patients are still in a post-ictal state. So don't expect patients to understand the complex issues immediately. So you have to consider the very individual impact of the diagnosis. Timing and content of communication needs to be tailored individually. And communication is not a skill that doctors are perfect at by nature. We need to train and teach this important skill. So a ship in harbor is safe, but that is not what ships are built for. That's a quote very relevant for patients with epilepsy. The goal is that patients should not be prevented from leading normal lives, but there is the challenge that seizure risks need to be realistically acknowledged, but at the same time, there should be an avoidance of unjustified restrictions. And this is a very challenging balance, which is different from patient to patient. Now, the first years after the diagnosis of epilepsy can be very challenging, and this is a qualitative study showing that patients in the first years after the diagnosis are in the state of vulnerability, uncertainty, and confusion, and that they face problems with navigating health systems, find and understand relevant information, and also find the right health professional to address their needs. It's important to support patients in this very sensitive and difficult period, and we need to acknowledge that in most countries there is a good service for difficult to treat or chronic patients with severe epilepsies, but it's quite hard to find comprehensive, reliable expertise at the beginning of the disorder. It's also important to recognize the high psychiatric comorbidity in epilepsy. Patients with epilepsy have at least a twice increased risk for all relevant psychiatric disorders, particularly depression. And this is not only true for chronic and long-lasting epilepsy. This comorbidity already exists at the beginning of epilepsy. And this is important to acknowledge because a comorbid depression is relevant for all aspects of prognosis with respect to cognitive problems, to treatment responses, to comorbidities and mortality, and also with respect to costs. Don't expect your patient to say, "Hey, doctor, I want to tell you I'm depressed." Patients don't talk about their depression. They don't know that they are depressed in the majority of cases. So, you really have to actively ask. And I advise to use screening instruments such as the NDDIE, as epilepsy specific screening tool, translated in most languages, and this should help you to identify depression, which can be treated or avoided by using appropriate anti-seizure medications, helping and providing psychological support, or using antidepressant medications if necessary. We also have to talk about side effects of anti-seizure medications. And this is a study asking patients which side effect they would tolerate in exchange for seizure freedom. And it's interesting to note that the least accepted side effects relate to psychiatry, to mood, to behavior, aggression, and to cognition. So these side effects we should keep in mind. And this is one reason why we prefer sodium channel blockers as first line treatment in focal epilepsy. So, psychiatric side effects are very important for selecting anti seizure medications and informing patients. Now, patients who are not well informed and don't participate in the shared decision making are often non adherent. And this is a major reason for unexpected seizure relapses. And it's also important to note that many patients, if they don't take their medications, if they discontinue their medications, they don't discuss this with their doctors. So it's really very important to have patients who understand and be aware of patients who don't ask questions, who don't criticize, who don't uh, uh, talk about doubts or anger. So this might be a patient and the illusion of shared understanding. So allow criticism, allow questions, allow concerns. You might phrase or adapt or tailor the information you give to your patient depending on the individual psychological situation. For example, we should discuss SUDEP. Perhaps not necessarily as the very first information for every patient, but you can frame this information depending on the patient you talk to. So, a very anxious patient, you should perhaps not inform about the frequent occurrence of SUDEP. On the other side, if you have a patient who is non-adherent, doesn't accept the diagnosis, a young man living on his own with frequent nocturnal seizures, you should be very clear about the realistic risks of dying from unexpected death in epilepsy. Now, finally, to conclude, it's extremely important to counsel patients with epilepsy. It's a very important skill. And as I said, it's not a skill we all are good at by nature. We need to teach this, use a word round with colleagues, and ask for feedback. Content and timing is important. Also, it's important to be clear. It is epilepsy. It was an epileptic seizure. Driving is not possible for at least a year. Be clear. Avoid medical terms. Check for understanding. Make a pause and ask, do you have any questions at this point? Include relatives and be empathic. Don't be emotional. Don't be offended, even if your patient might be difficult. Use additional materials available in all countries, available through the chapters of the International League Against Epilepsy. This helps to inform your patient and to prepare your patient for the next consultation. So define what I call a starter pack. So far, thank you for your attention. And in the next segment, Jakob Christensen will discuss important aspects of the long term considerations we need to talk about with our patients.
Hello, I'm Jacob Christensen. I'm an epilepsy specialist from Aarhus, Denmark. And welcome to this segment that discusses the prognosis and long-term outcome from the start. So today we're going to discuss some of the consequences of having epilepsy. And one of the most serious consequences of having epilepsy is the risk of death. So we're going to discuss mortality and use that as a basis of discussing how we will inform our patients. Because naturally, accidents and consequences of seizures is a concern of our patients, and the worst possible thing that the patient can imagine is dying during a seizure. So we'll use that as an outline to discuss some of the risks of having epilepsy. We'll focus on some of the particular risks of SUDEP, suicide, suicidality, and other causes of dying when you have epilepsy. We will focus on psychiatric disorders and consequences for cardiometabolic health. And finally, we'll discuss how we will frame this in the context of your patient conversations and when to actually inform patients about these risks. So in terms of mortality, we know that epilepsy is associated with losing life years. So actually, people with epilepsy live 10 to 12 years shorter than persons without epilepsy. Actually, this is more serious for males than for females. And what do people with epilepsy die from? So they actually die from the same disorders as everyone else without epilepsy die from, meaning that cardiovascular disorders is the number one cause of death. And that goes for both males and females. So on average, persons with epilepsy lose 2 years more than persons without epilepsy from cardiometabolic disorders. So that's important to remember when you have a chronic disorder. Also, we have more specific causes of death related to epilepsy. So one of them is SUDEP, sudden unexpected death in epilepsy, which also often occurs in the presence of a seizure. So following a seizure, people suddenly die. It often happens at night, and it's more frequent with people who live alone. So these will be risk factors for SUDEP. Also, suicide is a risk in persons with epilepsy, but it's important to remember that suicidality and suicide is a rare occurrence in persons with epilepsy. Those at risk for these events in terms of suicide are actually those with psychiatric comorbidity. So in that part of the population, the risk is very high. So how high is that risk? So this was estimated by FDA, who followed everyone who was randomized to treatment with anti-seizure medication regardless of underlying indication. And they found that the risk of suicidality, including both suicide attempts, suicides, and thinking of and planning suicides, were 80% increased in persons taking anti-seizure medication. But the absolute risk of suicidality, planning or thinking of suicide, was small. So does anti-seizure medication come with benefits? So although anti-seizure medication is associated with increased risk of suicidality, then anti-seizure medication is also reducing overall mortality. So it reduces overall mortality about 60%, but it reduces the mortality even more in those with at risk of SUDEP. So, what are the consequences of this, and how do I frame this with our patients? So, you will know as doctors that epilepsy in some cases can be associated with increased mortality. And what can we do to prevent this? So, the first thing you can do as a doctor is to make sure that your patient understands the diagnosis. Why am I diagnosed with epilepsy, and what are the risks associated with epilepsy? You know in the back of your head that there's increased mortality, but it's not always a good thing to put that up front for the patient at the first visit, but leave it maybe to a later discussion with the patient. But early on, frame that there can be risks of accidents, and think of those who are at particular risk. Focus your information to the patients to, if it's in terms of suicidality, to those with psychiatric comorbidity, and for those at risk of SUDEP, you will focus on those who have seizures at night and who live alone. So you adapt your information to patients knowing their risk factors, but make sure that the patient have a deep understanding on why they are diagnosed with epilepsy and why they need to take the medication. So it's important that the patient also needs to understand that they need to take the medication every day. So that is a bit different from other disorders where you can skip a few days maybe and still have the benefit of the medication. In epilepsy medication, you need to take the medication every day to be protected. And it's important that the patients understand that. Otherwise, it can have significant consequences for the patients. And what do people die for? Remember that people die from the same disorders as people without epilepsy. So actually, the highest contributor to mortality is cardiometabolic disorders. And how can we prevent cardiometabolic disorders? Yeah, one way of preventing it is actually physical activity. So it's important to also discuss with your patients that it's important not to stay at home, to feel the protection from the medication, and live your normal daily life, maintain your job as best possible, engage in education and social activities, and try and avoid a sedentary lifestyle that will then lead to cardiometabolic disorders. That will also help on your other metabolic disorders, such as poor bone health, that you can potentially prevent by being physically active. And it's actually a good thing as a person with epilepsy to be physically active. And there's no indication that physical activity in itself will aggravate seizures. But of course, you need to be careful not to be engaged in activities that could be associated with a risk of accidents if you have a seizure. So it's important to maintain good brain health. Being seizure-free is important. It's important that patients understand why they need to take medication. It's important that they understand that the potential risk of, for example, suicidality is much, much smaller than the gain that you will have in terms of mortality and reduced number of accidents that you can prevent by taking medication. So taking medication will help the persons with epilepsy participate in normal life and maintain overall good health and well-being. Thank you very much for your attention. In the next segment, Elinor Ben-Menachem will discuss some things you need to consider in people with epilepsy who are planning to conceive.
I am Eleanor Ben-Menachem, a professor and epilepsy specialist based at the University of Gothenburg in Sweden. Welcome to this session called Discussions on Conception in Epilepsy. We are going to be talking about male patients taking valproate, oral contraceptives, and anti-seizure medications, which we will call ASMs, and considerations in pregnancy with ASMs and folic acid. Now, first, we are going to talk about valproate in men. So the UK Medicines and Healthcare Product Regulatory Agency, as well as the European EMA, have all come out with warnings and the findings are based on a medical record study in Norway, Denmark, and Sweden, which indicate a possible increased risk of neurodevelopmental disorders in children born to men treated with valproate in the 3 months prior to conception compared to those born with men treated with lamotrigine and levetiracetam. Now, the cumulative risk ranges from 4 to 5% versus 2.3 to 3.2% with those taking lamotrigine or levetiracetam monotherapy. Now, this is anyway a much lower risk to the children born to mothers taking valproate during pregnancy, which have a 30 to 40% risk. However, we don't in this problem have a causal role of valproate. It is not confirmed, and as such, the advice from the EMA and the UK HMRA are precautionary. So the MHRA and the EMA want to inform male patients of any age who may father children of the possible risk at initiation of valproate or at their next review, whatever the indication. As a precaution, we now recommend effective contraceptive during treatment and for 3 months after stopping to allow for one complete sperm cycle not exposed to valproate. If men, therefore, are planning a family in the next year, they are to be referred to a specialist, an epilepsy specialist, neurologist specialist must be okay, to discuss alternative treatment options. Now, the directive is that valproate must not be started in new patients, male or female, under 55 years of age, unless two specialists, which may be a problem, independently document that there is no other effective or tolerable treatment or compelling reason that the reproductive risks do not apply. But we have to look at the background. Why is valproate used so much? Valproate is actually the most effective medication for generalized epilepsies and severe specific epilepsy syndromes. For some people, it'll be the only medication to establish seizure remission, and withdrawing it carries risks of seizure recurrence and sudden unexpected death in epilepsy, or SUDEP. It is also of proven efficacy for both bipolar disorders and migraine prevention. Evidence suggests that 30 to 40% of people switching from valproate will have breakthrough seizures. So it's not a little thing to stop valproate. Thus, in the UK, it's been estimated that 21 to 28,000 people will immediately be exposed to the potential hazards of breakthrough seizures, including death. Also, there is evidence showing increased attendance at the emergency room, hospital admissions, falls, injuries, and depression in men and women who discontinue valproate. So the stakes are very high, and it is really a controversy, and we all have to decide what to do. So, in conclusion, men with epilepsy taking valproate should be adequately counseled about the potential risks to fertility and increased teratogenicity if they stay on valproate, but also any potential harms are associated with coming off of valproate, and every patient has to know the pros and cons. So now if we go on to looking at contraception in women with epilepsy, enzyme-inducing anti-seizure medications, so EI, I'm going to call the enzyme-inducing ASMs, they reduce oral contraceptive efficacy. Thus, physicians should alert women using EI ASMs to the increased potential for unintended pregnancy if they use oral contraceptives for contraception. Risks can be reduced, however. They can be reduced by alternate forms of effective non-hormonal contraception, such as copper IUD, or by use of a non-EI-ASM, if and only if this will provide adequate control of their epilepsy. Lamotrigine can be affected by high doses of oral contraception. They can reduce the level of lamotrigine, so you may have to make adjustments in lamotrigine when starting or stopping oral contraception. ASMs can reduce effectiveness of oral contraceptives and increase unintended pregnancy. We can address this by switching to non-hormonal contraceptives like copper IUD, or switching to a non-inducing ASM that doesn't interact with oral contraceptives if it adequately controls their seizures. Now, the next controversy in the last one are considerations in pregnancy for women with epilepsy. And so if you think about anti-seizure medication, the major congenital malformations, MCM, are increased no matter what ASM you use. So in a normal population, the prevalence of MCM among children born to people without epilepsy is 2.4 to 2.9%. But with ASMs, even with lamotrigine, levetiracetam, and oxcarbazepine, which are deemed to be the safest, you still have major congenital malformations in monotherapy of 3.1, 3.5, and 3.1% respectively. So valproate, of course, is associated with the highest unadjusted birth prevalence of 9.7 of any MCM. So if this broadly aligns with the results of the European Pregnancy Registry, Europe, and it also in a study in 2023, which is a systematic review, a Cochrane review also aligns in showing that this is really what the prevalence is. So if you're counseling, I would refer you to a very good paper by PAC, and it's the American Academy of Neurology and American Epilepsy Society guidelines for teratogenesis and perinatal and neurodevelopment outcomes. So there is a evidence-based level here. And in this guideline, they say that clinicians must counsel their patients, that telling them that the risk of any MCM, even without taking a drug, is 2.4 to 2.9%. Now, clinicians must consider using lamotrigine, levetiracetam, or oxcarbazepine when appropriate based on the patient's epilepsy syndrome. But there you will minimize the risk of MCMs. That's level A evidence. And clinicians must try to avoid using valproate to minimize the risk of MCMs if clinically feasible. Level A evidence. And this is dose related, by the way. So under 600 milligrams is much less risk for MCMs with valproate compared to a higher dose. Now, with anti-seizure medications, we also know that there's a problem with folate because they can decrease the folate concentration. And children exposed to ASMs prenatally, with those born to persons using folic acid, they have a lower risk of adverse neurodevelopmental and preterm birth. But it remains unclear whether the risk of congenital malformations can be equally alleviated. However, an increased risk, this is a new information, an increased risk of cancer has been found in children of mothers with epilepsy using high-dose folic acid supplements in pregnancy, meaning 5 milligrams. So the recommendations now are that clinicians must prescribe at least 0.4 milligrams of folic acid. We use 1 milligram in Sweden during pregnancy. and this is at level A evidence. And clinicians should counsel women with childbearing age treated with an ASM that adherence to recommended folic acid supplementation preconceptually and during pregnancy is important to minimize the risk of MCMs and poor neurodevelopment outcomes. So, thank you for your attention. And in the next segment, Antonio Gilnagel will talk about making treatment decisions with our patients that are tailored to the individual. Thank you very much.
Hello, I'm Antonio Gilnagel, a neurologist specialized in epilepsy from Madrid, Spain, and welcome to this segment, Making Treatment Decisions in Anti-Seizure Medication Selection. After a drug is approved following appropriate clinical trials, there is a load of information that clinicians have to review and assume, including real-world evidence, clinical studies, and meta-analysis, Delphi, and other consensus, as well as expert opinions. And very frequently, we have guidelines. However, these guidelines might be outdated by the time they are in circulation, and therefore we have to make out our decisions based on our perception on efficacy and safety of anti-seizure medication. From this perception that is shaped over time, and it might change from month to month or year to year, we review the patient's perspective, and together we have to reach a consensus on which of the drugs that we consider most effective and safe might be the ones that benefit better the patient. What do we consider in terms of ASM selection? First, there are things that are related to the disease: the epilepsy syndrome, the etiology, seizure frequency, seizure type, seizure severity. This is important to consider here, the difference between a focal seizure without impairment of consciousness, when there is impairment of consciousness and therefore decreased autonomy and inability to drive, drop seizures, falls, generalized tonic-clonic seizures. But there are also other factors not related to the disease in itself, such as the sex of the patient, their age, what are the concomitant medications or other disorders that they are suffering, and of course, what is the characteristic of these drugs, the pharmacokinetic and pharmacodynamic interactions. Remember that many of these patients, when they go to your clinic, they were already started on an anti-seizure medication, and usually most of us will maintain the drug that had been started maybe in the emergency room. That very frequently is levetiracetam. But in focal epilepsy, if levetiracetam fails, or if we have the chance to start this patient on our preferred ASM, we usually prefer to start them on sodium channel agents such as carbamazepine, eslicarbazepine, and the list that you have in front of you. On the other hand, for unknown types of epilepsy where we don't know whether it's generalized or focal, and in those patients with generalized epilepsies, our preferred drugs are those with a broad spectrum, such as levetiracetam or brivaracetam or perampanel, and so forth and so on. In developmental encephalopathies such as Lennox-Gastaut syndrome, Dravet syndrome, and many other diseases, it's very important that we try to find the etiology. There is a large number of genetic variants, and when we know the etiology, the selection of a drug can be more precise. It can be, we can be closer to precise medicine in these cases. The safety profile, specific side effects should be taken into consideration because, as you know, these drugs, especially levetiracetam, is associated with mood disorders, with dysphoria such as depression, irritability. This is also the case, although to a lower extent, in the case of brivaracetam. In the case of perampanel, we have also these possible side effects, and especially the rate of aggression and psychosis is a little bit higher. But it has the added benefit that it can be given at night, and it's a good drug for inducing sleep, so it might be a good option for patients with
insomnia, and this is also the case for zonisamide. One single dose at night and might be a good sleep modulator. There are other drugs such as topiramate, but because of its side effects, cognitive side effects, might be relegated to later options. But still, it's a good drug for some particular disorder, especially in some encephalopathies. Nevertheless, even though we have these side effects that you see in this slide, remember that these side effects are dose related, so they might not be present when we just need to keep the patient in low doses. This is something we have to talk with the patients when they already have an idea of what is the drug they want, and they sometimes don't want some drugs because of the perceived side effects they have. It's important to state to these people that those side effects are dose dependent, and if they have a mild epilepsy and low doses of anti-seizure medication can be used, this is not going to be a problem with them. You are going to listen, or you have already listened to Eleanor Ben-Menachem's talk, and you have learned that our preferred drugs, because of their low rate of malformations, are lamotrigine, levetiracetam, oxcarbazepine, and zonisamide, and that also when we have to move away from these preferred drugs, using the minimally effective dose might allow us to provide adequate seizure control with a low risk of teratogenicity. Well, we have to get patients involved in the decision about what is the most appropriate anti-seizure medication. They have to understand that there is no one-size-fits-all approach in epilepsy therapy. And this might be difficult to understand for some of them because they usually approach medicine as, if I have this disease, this is a treatment, and there is nothing else I have to do about it. So it's important to have an open discussion with them about the pros and cons of selected options, obviously providing them with our most preferred option, but openly discussing this with them. Patients' concerns might be different. There might be some patients that are more concerned about side effects than seizure control. There might be others that they just come to the clinic reporting, I cannot have one more seizure again. So we have to understand what is their perspective and shape our conversation and decisions according to this. It is important to encourage the family participation. The perception of seizure severity might be different between the patient and the family members. And because they are the ones that are going to be there if seizures recur or if the side effects occur, they have to participate in this conversation. This conversation is usually taken together, the family and the patient with the physician. But on occasions, it might be good to have 3 different conversations. One, all of them together, the other one, the patient alone, and the other one with the family alone. When we do this, on occasion, we can see that the patient might be hiding information to the family because they don't want them to get concerned about their disease. Therefore, also the family might not be able to express all their anxiety in front of the patient, not to concern them too much. In these conversations, we have to balance the safety, the risks of seizures, and the side effects of the anti-seizure medication. And we have to consider specific situations, for example, age. The approach is different between an adolescent and an adult with a family which has to support kids and a wife, or a wife and supporting the husband. Therefore, in this situation, maybe seizure control in the adult is more urgent, while the adolescent, he wants basically not to take medication. He might be in denial. Compliance might be also different because of their motivation for seizure control is different. And in adolescents, it's usually preferred to have 1 dose per day than multiple doses, which is usually better. Cognition, side effects because of dizziness or the impact of the anti-seizure medication and other drugs might be also considered differently between more adults. Their working status, if if a patient is self-employed, their motivation for seizure control might be higher than if he's in a salary. And finally, it's very important to monitor occult and obvious side effects, which very frequently are reported by the family and other cases by the patient. And therefore, this conversation openly between families and patients and the physician are of the most important matter. With all this information in mind, I think that we can help our patients choose and have the best treatment options. And from here, I thank you for your attention. And in the final segment, Dr. Bettina Smith will conclude the program and recap the key points for you. Thank you very much.
Hello, and welcome to the final segment where I will conclude and briefly recap the key points of all of our excellent faculty. In the first segment, I gave you some advice for that first conversation with patients. Key things to remember are your perspective and that of your patients might be different. Their future path with epilepsy depends on how you set things up today. So always try to allow an open discussion and establish a trustworthy doctor-patient partnership. Remember to screen for depression regularly, not just for the records. Depression in people with epilepsy is treatable by adjusting anti-seizure medications, provide psychotherapeutic support, or introduce antidepressants, which are safe in most instances. Help your patients understand and retain all this information by regular appointments, encouraging questions, and allow concerns. Include relatives and use additional approved information material on paper or online. In the second segment, Jakob talked about long-term outcomes in people with epilepsy and what that means for good communication. We know that sudden death and suicide are more common in people with epilepsy than in the general population, and that people with epilepsy die earlier on average. But the biggest killers of people with epilepsy are the same things that kill the general population. Top one is circulatory disorders. So it's essential you help your patients properly understand all these risks to help put the benefits of treatment into a meaningful context for each individual and support overall health with good diet, appropriate exercise. Many patients with epilepsy avoid exercise, and managing psychiatric health. All support good brain health and will help our patients live better and longer. In the next segment, Eleanor talked about valproate in men, about contraception, and anti-seizure medication use in pregnancy. Regularly, authorities in Europe advised that men should be informed about a possible increased risk of neurodevelopmental disorders in children born to men treated with valproate. But we also need to advise patients of the risks of coming off valproate, since this is the most effective medication for generalized epilepsies. Since anti-seizure medications, depending on their interactions, can increase the risk for unintended pregnancies, the preferred mode of contraception should always be a topic when starting or switching anti-seizure medications in fertile women. Consider a non-hormonal contraceptive method like a copper IUD, not only because of lack of potential interactions, but also because of the higher reliability. It cannot be forgotten. The anti-seizure medications most appropriate for use during or before pregnancy are lamotrigine, levetiracetam, and oxcarbazepine. Please support the pregnancy registries such as Europe and report all pregnancies with anti-seizure medication exposition. We need more information, particularly with respect to the newer anti-seizure medications. And for women planning to conceive, folate doses of 0.4 to 1 milligram are needed in women preconceptually and during pregnancy to reduce the risk of neural tube defects, major congenital malformations, and poor neurodevelopmental outcomes in their children. All women who don't use reliable contraception should be advised with respect to the folate prophylaxis. And finally, Antonio gave his expert insight into how to combine all these considerations with each individual patient for appropriate anti-seizure medication selection and shared decision-making. He reminded us that there is no one-size-fits-all approach in epilepsy therapy, to have an open discussion about pros and cons of selected options, to understand the individual's preference for seizure control versus side effects, and to involve families in this discussion, and to consider specific characteristics like age, sex, comorbidities, mood, sleep, employment status, driving status, and drivers of compliance for that choice of the most appropriate treatment for your individual patient. So I would like to thank the excellent faculty for their presentations, and I would like to thank you for your interest and attention. And now please continue on to answer the questions that follow and complete the evaluation.
This program was presented by Medscape Education Global.